Hello, I'm Tony DeMaria from UC San Diego, and I'm here with Deepak Bhatt, well known to everybody, who's professor of medicine at Harvard Medical School. And we're at the TCT meeting where we're prepared to bring for you the highlights of the late-breaking clinical trials. And I guess the #1 highlight in an important paper was the EUROMAX study, Deepak.
Absolutely. In terms of really important trials that have the potential to influence practice, this ranks, in my opinion, as one of the top 2 or 3 of this TCT. And what this study did was examine about 2,000 European patients coming in with an ST elevation MI who were destined for primary PCI. What the trial did was randomize those patients either to bivalirudin, typically starting it in the ambulance, versus heparin plus optional 2B3 inhibitors. So in some respects, similar to the Horizons AMI trial that's been previously published, but building upon that trial, in a sense modernizing it by starting therapy in the ambulance, by having a higher proportion of radial artery access, and more contemporary oral ADP receptor antagonists.
Yeah, well, it's interesting that Bival and Horizons was superior
Yes.
in terms primarily of bleeding. How did it do in the ambulance?
So that theory of less bleeding with bivalirudin, well, I shouldn't say theory, it was seen in Horizons, was confirmed in this study. So despite the fact that half the patients had a radial approach, despite the fact that about half the patients got ticagrelor or prasugrel, so some would say a more modern approach to STEMI, the results with respect to bleeding were very consistent. That is, bivalirudin was associated with a significantly decreased incidence of major bleeding compared with heparin plus optional 2B3 inhibitor. And the optional 2B3A ended up being about 75% of the patients that got 2B3A in the heparin arm, 50% up front, or I should say 50% in the cath lab, and another 25% bailout. So the results with respect to major bleeding, very consistent, and about a 50% reduction in transfusions from about 4% to 2% with bival.
Yeah, so consistent with a benefit in terms of bleeding with bival.
Yes.
What about acute stent thrombosis?
So you're right to note that in Horizons AMI that was an issue, stent thrombosis within 24 hours being higher with bivalirudin versus heparin plus 2B3A in that trial. And the results here were similar. That is, stent thrombosis within the first 24 hours was higher with bivalirudin. And I guess the reassuring thing is there didn't seem to be any excess mortality. In fact, in Horizons, if you recall, there was lower mortality in the bivalirudin arm with a p-value less than 0.05. Now that wasn't seen here. There wasn't any significant reduction in mortality with bivalirudin in this EUROMAX trial, but I guess reassuringly there was no excess either. So the stent thrombosis, presumably because it's occurring still while in the hospital, must not have had a high case fatality rate.
So EUROMAX, answering the question about radial versus femoral, answering the question about prasugrel ticagrelor versus clopidogrel, still showing the bleeding benefit, moving us more toward administration of potent medications in the ambulance. You think that at your hospital, for instance, you're going to make preparations to do this?
That's a tougher question. The study didn't really examine ambulance versus no ambulance, so it's hard to say. I think it depends on local practice. In Europe, as you know, ambulance therapy, especially in some countries, France, for example, very common, and they deliver it very effectively because they're highly skilled personnel on those ambulances. I'm not sure how much that aspect can be extrapolated to the US. I don't know that the trial provides a mandate to start therapy in the ambulance. I think what it shows us is that bivalirudin is associated with less bleeding, and that's true even if you believe that a radial approach is the way to go in STEMI.
Yeah. Well, certainly we'd have to gear up, train individuals in terms of giving drugs like bivalirudin in the ambulance. And I agree with you. I think it's really interesting data, but we've got more to see before we implement that. A couple of interesting studies on bifurcation stenting. That's a problem that just won't go away.
Yeah, you're right. It's perhaps the bane of the interventionalist existence. There's nothing worse when you see really tight LAD lesion, a major diag involved. What are you supposed to do with that? It's hard to just leave the diag alone. But I think the data to date suggests the best strategy is one of provisional stenting. That is, stent the major branch, the main branch, typically the LAD in that example I gave, and then only chase after the diag if needed, if there's a degradation in TIMI flow or it appears to be a really tight lesion that you just can't leave behind. And in general, patients seem to do pretty well with just the stenting of the main branch. What these two studies did was examine a strategy of bifurcation stenting up front. The NORDIC trial examined just going ahead and stenting both branches versus the provisional approach, and found that the provisional approach was just fine, no advantage to stenting both. So that's largely confirmatory. The Tryton trial examine the same question but with a newer, fancier, dedicated bifurcation stent to see whether that might overcome our current strategies where we're just sort of engineering a bifurcation stent by throwing two stents in there. And the study results, I guess to put it bluntly, were negative. That is, the trial was examining non-inferiority of this new Tryton bifurcation stent versus a strategy of provisional bifurcation stenting with just regular stents that we've got, drug-eluting stents, and it actually didn't meet its primary endpoint of non-inferiority.
Yeah, well, for all the studies that have been carried out in bifurcation lesions, we come down to the simple thing, just stent the primary lesion and go from there. And all of these fancy stents just don't seem to bias very much, do they?
No, you know, Floyd Loop, the renowned cardiac surgeon who was my first CO at Cleveland Clinic, actually in the OR used to say diag disease never killed anybody. And obviously that's not strictly true. You can have a big diag and have VFib and diaphragm. But in general, the point he was making is that in surgery, you want to put a lima to the LAD. Sure, throw some vein grafts to everything else, but don't make the surgery overly complex to do that. And I think interventionalists should learn from that. Keep it simple.
Keep it simple. Well, these are really interesting studies, and there's lots more to come. We'll be with you in just a little while.